Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Should have peed. Oh.
Maybe I should have too, but we can cut after that, can't we? Let's see how we go.
Okay.
I'll tell you a story about that sometime, maybe. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel. Hi.
So today we're going to be talking about myocarditis caused by immune checkpoint inhibitors. Important subject. Interesting subject, I think, as well. But before we do that, I am going to ask you an icebreaker, which is best ever meal / most expensive meal / most expensive thing you've ever put in your mouth. Delete as appropriate.
Okay. I'll start with the last one only because it just came to me. I should probably ask you a related question. So, I only have one New England Journal publication. And after it got in print, I drove to a nice wine shop in Houston. It's actually not a nice one, but I don't want to call it a slummy one. And I bought one of my favorite bottles of champagne. It's Krug champagne, Krug. And then also I had the receipt for a long time because the receipt was, a crazy receipt, basically. I think I got some Cristal, which is Louis Roederer, I think. And then I got a Krug. And then I proceeded to drink most of one of those bottles that night. That's probably the most expensive thing. But that's related to the best meal because the first time I had Krug was on an ANA flight. It was DC to Tokyo. I was on my way to Shanghai, but I was cashing in some points to do DC to Tokyo in their first class product. So not their business class, but their first class. I think their first class only had 4 seats in it. 2, 3, maybe 6, and 4 were occupied. Basically, it wasn't full. It's the biggest, thing I've ever sat in. And then because it wasn't occupied, the flight attendant, you have your own personal flight attendant. So I had my own personal, Miss Sato, and she made the bed next to me into the bed. And she said, you can live in your seat, but you can sleep over there. She gave me the pajamas to go change into. And I didn't realize when I went to the bathroom to change into them at the start of the flight, the bathroom had all these things in there. It had a scale so you could weigh yourself in the bathroom. It had perfume bottles and all these. So I was just taking my time playing with things in there, taking off all my clothes, weighing myself fully naked, weighing myself with the pajamas on, just taking my time.
Were they heavy, the pajamas, or not? Or, do you
remember? No, they're very light, nice, Anyway, I hadn't really realized how much time I had spent in there, but I knew I had spent a load amount of time in there. And the other 3 people had already either come and gone or whatever. But
you didn't have your own personal bathroom?
I did not. But it took, longer than would be expected. And I came out and she had been waiting the whole time. She had been waiting with a hanger because she wanted to hang my existing clothes. And I didn't realize, and I was mortified that I was just standing in there playing and weighing myself multiple times, taking precise measurements. Anyway, the meal service on that flight was, to date, probably one of the top 3 meals of my life. It was just seafood course after seafood course after seafood course. I think it was something like 10 courses. Unbelievable, the quality of this. And I don't know how you can do that at 30,000 feet, but it was phenomenal. And they had Japanese whiskey. They had the Krug. When you get the Krug, she comes out with the whole bottle and she pops it just for you. And anyway, it was just phenomenal. So that was one of the best meals of my life. It just happened to be in the air. And then it's where I learned that I really liked that one champagne. And then probably that equated to the most expensive thing I ever drank.
Yeah,
Do
nice
you,
answer.
does that
Does
jog
that
a memory
answer?
for you, maybe?
No.
Oh.
Yeah, let's do that another time.
Oh,
Not sure what memory is meant to jog. Sorry about
about
background
a
noise.
meal, about a really nice meal or expensive meal, or I don't know.
Oh, yeah. No, let's do it another time, honestly. Let's do it another time.
Okay.
So it'd be a long story otherwise. Okay, so myocarditis. Do you want to sort of start the story on myocarditis? Because there is a story here, actually, which is kind of good to understand, maybe.
Yeah, I don't know what story you're referencing other than, it comes up in the real world. We both have had a couple of these cases lately where it's just caused us to talk about it, talk about the management. Then of course, um, I have a great fellow right now who's really interested in this topic and has been kind of pulling together the cases. And it made us, I think in her research, she pulled that New England Journal of Medicine case report. It was the two cases of fulminant myocarditis published by Doug Johnson and the group at Vanderbilt back in 2016. And I think it's, as we think about 2016 and now 2025, um, there's a potentially long and winding road here as to what is the mechanism of myocarditis. What is our understanding of any baseline predictive markers? How do we even diagnose this when a patient has it? Because they don't come in with a sign that says check my troponins. And I don't know how many of us are routinely checking troponins. It's not indicated in the label of these checkpoint inhibitors. And then, of course, when it comes to management, is it just like all our other IO talks and we should just use high-dose steroids, 2 milligrams per kilogram? Or are there other strategies specific to what's happening? In Houston, there's some cardiologists doing work on this, looking at actual myocardial histopathology in patients having ICI myocarditis and saying there might be a small cell version, there might be a large cell version. Maybe not every case warrants the use of steroids. Maybe it's worth being more judicious. I know you have a mate out there that's cardio-oncology, kind of one of these global experts helping to help us understand how to sort of diagnose and manage this.
Yeah, you don't get that many case reports as original articles in the New England Journal of Medicine about side effects of drugs that have already been around for a little while. I mean, that's quite striking. And I remember when I read it, actually, the thing that struck me most was I was scared, actually. I just thought, wow, this is a frightening side effect. And I guess even then, we'd probably all seen a few patients that it was, at least sort of somehow in our awareness. But I think that really brought this whole thing to the fore for a lot of people, maybe who hadn't seen it. And, it's a nice paper. So to ask one question, do you think where we are 2025 is the same as where we were 10 years ago with this or not? There is definitely greater awareness, right?
Yeah, I mean, I had asked you on an earlier podcast episode, or maybe I just asked you casually if you had ever seen anybody recover from myocarditis, or was it essentially uniformly fatal? And you said without missing a beat, oh yeah, you'd seen people recover. And I think at the time I read this, I had a similar reaction to you, which is like, wow, this is scary and something to be very aware of. And when it happens, it can go wrong in a way that makes it fatal. And I think, I mean, touch wood, I didn't have so many cases in Houston where I thought, this is going to sound weird. So let me think about it before I say it. I guess the cases I saw in Houston when I would round in the hospital were significantly serious that I'm not sure I had seen a lot of recovery. I wasn't following a lot of these patients in my clinic that I had seen with some version of myocarditis that had then recovered, but I had certainly seen them when I rounded in the hospital, and they were almost uniformly unrecoverable. So I was likewise pretty concerned. I don't know that we know a whole lot more about myocarditis 10 years later, meaning I don't know that we know who's at risk for it and how to monitor or even pick it up necessarily. There's still some controversy over cardiac MRI versus a cardiac biopsy, et cetera. But I do think we are smarter at when we think something's gone wrong, what are we doing with the immune checkpoint inhibitors and how are we managing that side effect? That I think we were not doing 10 years ago. You've made this point before, right? Which is if we didn't know somebody was smoldering with the myocarditis, we were probably still continuing the insult, the immune checkpoint inhibitor, inadvertently until the myocarditis declared itself. So then they got more of the insult, and then potentially we were coming at it with just the one size fits all steroid. So that I think we're better at 10 years later.
Yeah, I mean, definitely this whole smouldering thing. I think smouldering is a great word. I mean, I saw a patient in clinic this morning, actually, and what I said to her, actually, she was on neoadjuvant treatment, and she was sort of maybe halfway through something like that, and she had itch, and she had some fevers. Eosinophil count was going up pretty significantly, actually. And I said, well, look, your immune system's almost certainly activated here. There, at the moment, I'm not sure exactly how this is going to land in terms of organ system involvement, but you've definitely got some sort of smouldering side effect here. And she was due treatment today. I didn't treat her. I just said, look, we're just going to watch this for a little bit. And I'm not sure I would have had the same awareness myself 10 years ago. And I think this is really relevant for myocarditis because some of the early symptoms can be very non-specific. People don't walk in, to your point, in cardiogenic shock or, with a serious ventricular arrhythmia or any of these things. I think a lot of these people, there's a prodrome there. And a lot of that stuff's going to be symptomatically subtle, maybe confusing. But then I always think to myself with these patients now, which I wouldn't have done 10 years ago, okay, let's do a troponin, let's do a CK, let's do an ECG today. And then quite often you'll pick up something in these patients. And so there's a sort of lead time bias there, if you want to call it that. Go on, carry on.
Maybe, unless you know it off the top of your head, we could put in the fact check. Are you familiar with the grading for myocarditis? What constitutes grade 1, 2, 3?
No, I'm not. We'd need to fact check that.
It might be nice for us to. And particularly, I mean, I don't know that I have a good handle on what percentage of our population over the age of, say, 55. You see how I was careful to use age 55?
Extremely careful. Noted. Thank you.
I don't know what percentage of the population is walking around with a subclinical mild elevation in their troponin before anything has started.
Yeah, a good question. And I think I said this before as well, but this comes up in kidney cancer the whole time with using anti-VEGF drugs and trying to monitor. I think one of the trials we actually published this, I think Brian Rennie's the lead author. This was it's called Javelin 101, axatilimab avelumab, and we actually had characterization at baseline of these parameters, at least in a kidney cancer group, so tending to be a little bit older and vascular paths and so on and so forth. But it's a fair point, and I think that's one of the arguments for considering sort of baseline screening, so that then interpretation subsequently is easier. But you raised a good point. What do you do with the sort of borderline values? I mean, it's a nightmare, obviously.
Yeah, other than to chart it, at least you have a baseline.
Yeah.
And then, of course, I don't know, do you know, or is one checkpoint more than the other prone to myocarditis? In other words, is it the CTLA-4, the LAG-3, the PD-1? So now we're getting into the realm of triplet checkpoint, where even the drug companies themselves are not sure. So there may be a little bit more attention paid to baseline troponins and then checking at set intervals versus checking with symptoms. But I don't know if I understand. I do know when you knock out LAG3 in a mouse, you get significant cardiac side effects. But clinically, we've kind of talked about this. Do you see it more with certain drugs than others? We're just more attuned to diagnosing everything, hypophysitis, adrenal insufficiency, everything across the board. I'm not sure if I know which checkpoint is really driving myocardial dysfunction.
No, I mean, I don't. And of course, in the literature, as it were, unsurprisingly, as things stand at the moment, it's Ipi/Nivo that's most closely linked, but that's almost a tautology, I would have thought. And that's a pretty important question. We've talked about it elsewhere. We don't need to talk about it again. The whole kind of LAG3 story, as it were, in terms of the kind of early data and concerns, which don't subsequently seem to have been borne out, at least. But I think we'll learn more about that in the future. And your point about triplets is an excellent point as well. So there's a fair amount of work now trying to understand the biology, and some nice papers, right, in recent years about this. And of course, one would hope that in doing that, it gave you screening tools for people to predict who might be at increased risk. But I don't think we have that at the moment, do we? No, in clinic.
No. And interestingly, there are a couple of things based on the biology. I mean, we looked at this Nature paper from Justin Balco, also from that Vanderbilt group, was on that New England Journal of Medicine paper, where they see T cells, TCRs against alpha-myosin in these patients or mice who develop fulminant myocarditis, suggesting that alpha-myosin might be one of these antigens that can trigger this. Interestingly, that means in patients, there may be a circulating marker that we can look at for TCRs or for this bit of antigen, this epitope. I guess it'd be hard to pick up the epitope, but there may also be tumor-specific antigen that may sort of induce this TCR release in a similar way that this alpha-myosin does, whether that's mimicry or who knows. I guess what I was getting at is there are many data sets now where we could potentially interrogate this. I think of our SWOG data sets where we have, a huge adjuvant trial of 1,300 patients treated with Pembro-Ipi, where we annotated the myocarditis events and the other kind of myocardial things. All the checkmate data sets in advanced disease that should have that. And these data sets have not only well annotated adverse events and then clinical outcomes, but they also have things like plasma on these patients banked. At baseline, they probably have on treatment plasma. They might even have some tumor tissue. So as we get a little bit more refined about honing in on a mechanism, a possible cognate antigen, or a TCR sequence that might be responsible, kind of have some data sets where we could potentially validate that in patients who developed the side effect and then the control patients who didn't.
Yeah, those are all good points. So how do we manage it? What are going to be the kind of take-home messages, do you think, in the clinic?
So, I think, actually, again, for the fact check, perhaps in addition to grading myocarditis, perhaps we should also review our NCCN and EORTC or ESMO guidelines for managing myocardial toxicity. At one point I looked through the NCCN tox booklet. Everything started with steroids. Everything. Colitis, transaminitis, dermatitis, everything starts with steroids.
Apart from endocrinopathies, maybe.
I think those start with steroids even. Yeah. Yeah. And actually, I disagree with that because I just think you need to replace the hormone that's deficient, start there, I don't
Yeah. Yeah.
necessarily think, but I think thyroid toxicosis, things like that, they still have steroids in there. Regardless, again, for the fact check, I'm sure the guidelines suggest steroids are to be used, but you and I both have clinical experience that, yeah, you can use steroids, but coming in pretty quickly with a steroid sparing agent is often useful. JAK inhibitors, CTLA-4 manipulating agents. So I'm curious your take. Should we be do you use steroids and then come in with a JAK inhibitor, or do you try to spare somebody steroids and start with something like a JAK inhibitor first?
No, I think for this, if you're treating someone, and so then that gets back to grading, and I think steroids are standard of care. I mean, it feels a bit like colitis in a way. If you're treating someone, there's going to be a group of patients in there, same with colitis, who are actually going to respond well to steroids. I don't think there's any doubt about that at all. We tend to use higher doses. Most of the guidelines will stipulate higher doses, sometimes even very high doses of steroids. Has that been clinically tested? Of course it hasn't. But I guess part of the driver here is we've got patients, sometimes at least, who are very sick. And so then you don't want to be messing around with low doses of steroids if you've got someone really sick. So I think that's, you could make a similar type of point with some of the neurological toxicities as well. If you've got someone who's really, really sick, you're not going to go in with a low dose of steroids. So I think that's that. I think until relatively recently, there hadn't been that many other thoughts about other drugs. And actually, this was a bit like the early days of colitis as well. It feels to me that it took quite a long time with colitis, certainly for me anyway, in my kind of clinical practice, to be thinking carefully about this question of when do we go for a second line agent. And certainly the early days, Ipi-mono, this is now 10, 15 years ago. With the benefit of hindsight, I'm almost horrified because we were just using high doses of steroids in people that weren't really that sensitive to it, which we don't anymore. And I must say that my kind of view of treating other toxicities has been informed by that now. So, the examples of that might be transaminitis, where you might go in with mycophenolate, let's say, as a second-line agent quite early on, if you're not getting the level of benefit and sensitivity that you want for steroids. And then applying that to myocarditis, if it's steroid sensitive, great. Hopefully the patient will clinically improve. You'll usually have a marker, troponin, that you can follow. But I think my point would be if they're not sensitive to steroids or insufficiently sensitive, in other words, you get control, you wean the steroids, and then things flare up, then I think that is exactly the time that you should be thinking about another agent. And I think I've read some of the guidelines recently, and all the guidelines, I think, suffer from this problem, if you want to call it that. And the problem is mainly lack of evidence, actually. And the whole space is hamstrung by lack of good quality prospective data. But when it comes to second line agents, steroid sparing agents, whatever you want to call it, it's usually a laundry list, to use the US vernacular. And it will almost always say consider X, Y, Z, A, B, C, D, E, F, G. And the problem with that, and I actually made this comment to one of my colleagues on Friday, and we were talking about we're talking about triple M. Maybe we should say something about triple M. Is that if you kind of look at the myocarditis box of triple M, it says, the guideline I was looking at the other day, consider tacrolimus, consider infliximab, consider abatacept, not abatacept, CTLA-4 agonist, consider Ruxolitinib or JAK inhibitor, and then maybe there was something else. So tacrolimus as well, actually, on this. I won't say which guideline it was. And I said to, my name's not on this, but I said to one of my colleagues whose name is on it, I actually don't think this is very helpful, just having a laundry list of 5 drugs, because that implies that the level of evidence, and it's not high quality evidence, but there is a different level of evidence, in fact, for those options that I gave you. I'm not sure anyone's really rushing to give tacrolimus or infliximab, or I'm not anyway, to these kinds of patients who are failing steroids. Whereas I think, or mycophenolate for that matter, actually, which is mentioned in some guidelines, I think that the data such as they are for abatacept and ruxolitinib and probably other JAK inhibitors is stronger than all of those other drugs. So I actually don't think the guidelines should be saying consider. I think they should be saying actually recommend, say abatacept, recommend ruxolitinib, recommend both together if you like. Anyway, so yeah, so that's my take on that. And I think to kind of cut a long story short, in my mind, and I think the evidence reflects this, the main drugs to think about in this space would be abatacept and ruxolitinib, or the two of them together. Right, that was a long speech, eh?
Yeah. Yeah, but I think you make the point. I mean, tell me if I am getting this right. Look, any one of us can do the exercise of pull out your favorite immune suppressant
If
for
you have one,
solid.
do you?
Yeah,
What's
well,
yours? What's your favorite immunosuppressant?
I don't mind tacrolimus, but that's for thin stuff. Uh, but I think anybody can go through the exercise of, can you make me a list of immune suppressants that you could use if steroids are not giving you the result that you want?
Yeah, I
And you
think
can read
Hamish could do that, actually.
your
Carry
dog,
on.
dog, your cockroach, very soon. So I think, we could look at GVHD, we could look at solid organ transplant, we could look at a lot of places to pick out an immune suppressant. But is that exactly the hammer we want to hit this nail with? Similarly, I think maybe you were making this point, are high-dose steroids the hammer we want to use to hit this nail? Yes, there will be a portion of patients who are sensitive to it, whether it's colitis or myocarditis. The question has come up, could we use any of those TNF alpha or other immune modulating agents in the front line and spare your T cells? And that's what we're getting at here with the myocarditis. You've gotten a side effect that will now really make you think about resuming ICI down the road, which we can talk about now or in another episode. You've got the side effect that is affecting a critical organ, which we need to recover from. Are steroids exactly the right thing, or is it just a big, massive hammer? So the thing about that laundry list that you were describing is they all have these different mechanisms of action, right? Tacrolimus is toxic specifically to the T cell receptor, FK, whatever is the generic, I'm forgetting. So, like one is going to target T cells. Ruxolitinib is JAK2. You're going to have CTLA4 agonist. You're going to have TNF alpha. The thing that I've never liked that I see us do with some of these very serious toxicities, neurologic toxicities, skin toxicities, is we target both T cells and B cells, in which case we're just throwing our hands up and saying, we don't understand anything about the mechanism of this. And we're going to use the biggest, least refined tool possible. And this happens in the neurologic and let's say derm worlds all the time where steroids are used. Bullous pemphigoid comes to mind. Bullous pemphigoid is an antibody mediated separation of your basement membrane that leads to these bulla. So if it's antibody mediated, I mean, a few things come to mind. Exchanging those antibodies out of the system might be one approach. Immunoglobulizing those antibodies with IVIG might be another. Taking down the B cells with an anti-CD20 might be another. Yet we almost always start with steroids, which are targeting the T cells. And of course, B cells help the T cells, and we realize there's an interplay here. But this is the issue that I think comes up for me. Now, I think myocarditis feels like it's a little more T cell mediated based on some of the biology. But I think it again gets to the point of, can we come up with a set of guidelines that is using a more specific hammer for this problem rather than just whacking it with steroids and then coming in second line with something else? Would we ever get so brave as to use a JAK inhibitor first without the steroids? What do you think? Not right now.
Not in someone who's sick. I mean, I think that the sweet spot for doing trials here, which we'd love to see, but that's been the case for the last decade now, I think, would be the sort of more intermediate types of people where they're not symptomatic, maybe got an elevated troponin, kind of room for manoeuvre. And to your point with biology, correlative biology, because that's going to be the crux of this. If we're talking about personalized immunosuppression or tailored immunosuppression. So quick intra podcast fact check, which is tacrolimus, FKBP1212, FK506 binding protein. Yeah, so there we go. So that's nailed that. And then something else I was just thinking about when you were talking is the triple M, myositis, myocarditis, myasthenia gravis. Quite well recognised now, which is great. People know about it, think about it. But actually, one of my ex-fellows now back in Australia, Sonia, messaged me on Friday about a patient they had who's really sick with triple M, saying, you know, and it gets to this point exactly about your choice of immunosuppression, because there's some stuff you might want to do for some of the bits of the M that you might not want to do for other bits of the M. And I said this in a message to Sonia. I said, I think if you've got a patient like that, then you actually think, what's causing the biggest problem for this patient at the moment? Is it the myasthenia? Is it the myositis? Is it the myocarditis? Myositis on its own in and of itself, does that ever cause major problems? Well, maybe not as often as the other two, first comment, usually sensitive to steroids. Whereas with myocarditis and obviously with myasthenia, your strategy is going to be different. And sometimes there's going to be some conflict there between your overall therapeutic strategy. So there's no right answers here, but I think you have to think to yourself, well, and actually this was a patient where the myasthenia seemed to be dominant, actually. And so guess what? I said, well, actually focus on that. And then vis-a-vis steroids, what's the myocarditis looking like? What's the myositis looking like? Maybe you don't need too much steroids there. Go on.
Yeah, as I often tell our patients, well, let's play the hand that we're dealt. Let's not play for a future hand. So your point I agree with is let's treat what's the most problematic of the triple M. However, and maybe stay tuned is the only thing I can say. Our fellow is looking into this. It may be that it may even be the asymptomatic one of your triple M's that ultimately dictates how well or how poorly these patients do. And we just don't know yet because this is kind of an understudied phenomenon. And then the other thing I was going to say is in one of these editorials, so one of the other pieces of articles that we reviewed in looking at this topic was the 40 patient series that was published in Clinical Cancer Research in 2023, I think. It was the series from France of 40 patients from Salpêtrière. Is that how you say it? Salpêtrière
Yeah, I think so.
University Hospital, where they treated patients initially with steroids and then they came in with, these JAK2 inhibitors. But a couple of the editorials that then were written about this was in Cancer Discovery.
Cancer Discovery, yeah.
Yeah. One was in Nature Reviews Oncology. They sort of talk about potentially screening for respiratory muscle failure. I don't know how you feel about that. Is that something you're thinking about when you're going to use maybe a JAK2 inhibitor? Like where does the screening for respiratory muscle failure actually come in clinical practice or not yet?
What, the respiratory muscle weakness?
Yeah, like do you actually think about that clinically when you're thinking about using a JAK inhibitor or CTLA-4 agonist or,
No, not particularly. I mean, that wasn't the biggest. I mean, I thought that editorial actually was really nice. Michael Dugan, this is, I'll just cite it, Cancer Discovery, it's at Mass General, May 23. But, for me, the biggest thing I guess I agree with was the downsides of immunosuppression. And I've sort of hinted at this a little bit already. So sure, if someone's really sick with bad myocarditis and they haven't responded to steroids, I can understand why, if you can, you would want to go in with abatacept and ruxolitinib. because effectively you're giving maximal therapy there. But I don't think we're seeing that many patients anymore well, I'm not anyway, who really got that severity of myocarditis for some of the reasons maybe we've talked about already. So I also don't like the idea of just kind of throwing the kitchen sink at it, because I want to know, which drug is working. And I have to say my experience, I think, and my interpretation of the literature, such as it is that in unselected patients biologically, is that ruxolitinib would probably be my preferred option over abatacept. The kind of interesting thing here, there's loads of interesting things here. So one, and it comes up in the editorial, is, well, what about the consequences for tumour response? And we talk about that a lot with steroids already. And, if you had to pick one, ruxolitinib versus abatacept for most favourable profile in terms of not losing your immune response to the cancer, which one would it be? I don't think there's a right answer to that, but it's not a minor issue. But it would kind of point me towards using one, I think. And then the other critical question here is, how long do you carry on your immunosuppression for? And we've talked about this, and we do talk about this quite a lot. As you know, I think in general, I think we agree that we're over immunosuppressing our patients in general for side effects. And maybe just to talk about a patient that I'm treating at the moment, which you and I talked about before, where we're using ruxolitinib. So this is someone who initially was steroid sensitive, but then lost their control of the toxicity, the myocarditis, during the steroid wean at quite high doses of oral steroids. Completely well, by the way. This is asymptomatic troponin rise. And we used 4 weeks of ruxolitinib to really rapid, dramatic benefit. And then I was thinking to myself with colleagues exactly this question: do we just stop at 4 weeks? And that's what we've done with JAK inhibitors when we've used them for colitis, or do we give more? And there isn't an answer to this. So we stopped. And this is a couple of weeks ago now, but just over the last few days, the troponin started going up again on a reasonable dose of steroids. So we're going to put the patient back on ruxolitinib. So at such time as we do have prospective trials, we'll hope for biology. We'll hope for steroid-sparing design where appropriate. And we'll also hope for something on duration of treatment for steroids, because these are with a marker, one would hope, or a readout you can titrate against. Yeah, so I thought that was maybe the other thing I'll just chuck in here as well, actually, is that these trials have been quite difficult to do across the board for side effects. There isn't that much interest from pharma, if we're completely honest. And then sometimes if we're talking about repurposing drugs with other indications, JAK inhibitors are a great example of that. This is not a big issue for the companies that make them, even though it's a big issue for us and for our patients. Right, that was another speech. That's 2 speeches.
No, it's good though. You brought us all the way to the sort of practical management. Can I ask you maybe some rapid fire practicalities that you probably think about? Are you screening any specific patient population at baseline with any sort of anything for myocarditis?
The only ones might be people who've had it before, and I'm re-challenging, and I have done that in the past. Is there anything else that really makes me think this is someone who needs a kind of myocarditis screen? No, honestly, not really. I don't think. Go on.
I can tell you, not guideline based. Anybody who I think just has sort of that cardiac risk profile. So this would be sort of men of a certain age.
What's the definition of certain?
I know I was going to sort of reach into 55, but I'm going to be a little more liberal and say 60. But, cardiac risk factors, maybe family history, hypertension, hyperlipidemia, age, smoking, any of these reversible, irreversible risk factors. I might get a baseline EKG and baseline troponin and CK on them, just again to establish a baseline so that if they run into trouble. I feel a little harder to know where that cutoff is in women. So I'm not so sure, is that a 70-year-old woman, or should it be a 60-year-old woman, or should it be the same age, just I don't know. So I can say I find it easier to just get an EKG and a baseline troponin and CK in men of a certain age. Number one. Number two, when somebody comes and you're starting to suspect this, what is the blood and or, let's say, cardiac testing you do to try to get to the bottom of it?
If it's just kind of gut feeling in clinic, i.e. something's not right, probably do an ECG, obviously in US terminology, CK, troponin. And if all normal, but I'm still got a gut feeling that this is someone who's brewing some side effects, don't carry on with immune checkpoint inhibitor treatment, put that on hold, see the patient again after a shortish interval. If they're completely well, what's a shortish interval? A week or half a week, I would have thought, and just keep watching. And almost always in my experience, this thing will come out in the wash, meaning you'll find out what it's going to be. And it's just a question of how long it takes.
What's the role in your practical clinic management of a BNP or an echo?
BNP, very difficult to interpret in my experience, all sorts of different things. I mean, I had someone in the other week with enteritis, I think. I don't know if I told you this or not. And I think the patient had a couple of bursts of paroxysmal atrial fibrillation. BNP was through the roof. CK normal, troponin normal. So I find it difficult to interpret BNP is the short answer to that, and not very specific. Echo, I might not even rush to do it. If you've got concerns about LV or RV function or pericarditis or tamponade or anything else, yeah, of course. For diagnosing myocarditis, it's not a great test. And so we're lucky, Alex, my friend, Alex Lyon, you've met him, who's a big cheese in this area. We have great service from him and his colleagues. And so actually we get cardiac MRIs quite easily when we need to, which is the test that you really want to do for diagnosis, I think. And they're doing a few PETs now as well. Yeah, that's quite cool.
But you have to be on a special diet before you can do that PET.
Really?
Yeah, because otherwise your heart muscle lights up. So you have to be on a high fat diet. So the heart switches from glucose to fat. So it doesn't light up as well. And now you can then discern, metastasis versus functional issues on the PET scan a little bit better.
Wow, I didn't know that. And so what, fat only, or what do you exclude?
We had a nice list in Houston that we used to give people where we wanted to do this, where basically if they were eating their normal carb heavy Western diet, we wouldn't be able to read, the FDG portion of the heart. So they have to be on pretty much high fat, very low carb, but I don't know the details for
Keto.
3 to 5 days. Yeah.
3 to 5 days.
Yeah.
Wow.
Okay. Just a few more, just in rapid fire. So, when you order a troponin, are you ordering a troponin T, a troponin I? Your friend Alex had talked to us about, the high sensitivity one versus just the turnaround one that you get in the hospital. But
yeah, so normally we do troponin T.
Okay,
Is the long and short of that.
Yeah. So then you're diagnosing somebody with whatever, we'll put it in the fact check, grade of myocarditis. You start them on steroids. Just talk me through day 1, day 2, day 3 of steroids and what you expect the troponins to do, and where you would be thinking it's suboptimal response and you need to come in with something else.
Yeah, so those are all good questions, and I can't give you a straight answer. So just more broadly, most of these patients have been admitted to hospital by definition. Are there any issues about heart rhythm? Where does or LV function? Where should the patient best be looked after? And we're a specialist cancer hospital, so some of these patients need to go to the Royal Brompton, which is just over there, which is a cardiac hospital for monitoring, etc., cardiac supports. That's one thing. If I hadn't had some sort of stabilization of clinical trajectory and biochemical parameters actually by 24 hours, I would be a little bit worried and someone's sick. But what would you do then? Well, if they weren't on a really high dose of steroids, honestly, I would then go for a really high dose of steroids, half a gram, something like that. This is someone sick we're talking about. And I think if by 48 hours in the same patient, if you really haven't got any kind of stabilization or improvement, that's when I would go probably for ruxolitinib.
Is the ruxolitinib being brought in A, because your troponin is still climbing, or B, because the troponin is flat? You're not bringing it in when the troponin is actually nicely decreasing.
No, I wouldn't. The answer to that is no. But, then you're going to, at the far side, they make the patient stable, they leave hospital, they're still on probably quite high doses of steroids as an outpatient. And that's the other scenario I think I would be thinking about ruxolitinib. If you've got someone who was, and it's like the patient I just mentioned, steroid sensitive, but they're not anymore, the troponin is starting to go up on significant doses of oral steroids, then I think that's another place to think about a steroid-sparing agent.
And then you bring in the ruxolitinib, and what are you doing with your steroids behind the scenes?
And once I've got the problem under control, in other words, patient fine, troponin going south, then I'll start to wean the steroids. My argument there would be this isn't someone who's actually particularly steroid sensitive anyway. We don't want the patients to be on high doses of steroids, obviously. And then you're also monitoring the patient carefully. So, I would always try and wean steroids if I'm in a position of stability.
And there's a lot of controversy here. This might be in your Hitting the Sweet Spot article, but weaning steroids means different things to different people. I watch people wean steroids over 6 weeks. But in the case where you think I'm using my secondary agent as my heavy lifter, in this case, you would wean steroids over a week or so.
Yeah, I try and go quickly if I can. But with appropriate levels of monitoring, obviously, as well. With the right patient too. It's worth saying that because there can be sometimes some issues about compliance, coming up to the hospital, getting blood tests done, all that sort of thing as well. So, but yeah, in an ideal world, I'll go quickly.
And then release from hospital is at normalization of troponin or CK, or just at a very nice downward trajectory?
Oh, in terms of discharge from being an inpatient, downward trajectory is good enough clinically well. I mean, when it's kind of turned the corner, as it were. So you maybe want a day or two of the right trajectory, and then you think to yourself, well, why then hospital anymore? You don't need to monitor them as an inpatient.
Yeah, it goes to your points about compliance and all that, but still, yeah. Okay, what else do we need to say about myocarditis?
I think we covered a lot. We talked for quite a long time. We didn't even really talk too much about the science, which is quite cool. There's loads of nice papers on that. But I suspect we'll talk about this again as well.
Okay. Well, thanks for this.
Thank you.
Good conversation. All right.
Yeah.
Hi, everybody. This is a fact check for our episode myocarditis. Over to you.
So I think we're going to start with CTC grading. Maybe that's an easy place to start. Version 5, there is no grade 1. It's always interesting when there isn't a grade of something. We could go on a massive digression. I could ask you if you know of other toxicities where there is no grade 1 or nothing beyond grade 2 even. But so grade 2 is symptoms with moderate activity or exertion. Grade 3 is severe with symptoms at rest or with minimal activity or exertion. Intervention indicated, new onset of symptoms. 4, life-threatening. Urgent intervention indicated, e.g. continuous IV therapy or mechanical hemodynamic support. Grade 5 is death. So, moderate, severe, life-threatening is the simple summary, grade 2, 3, 4. So that's the CTC grading.
I have some comments about that.
Go.
So, I mean, you and I have talked about this, that the cardiologists will often bang on about this. That's not a helpful grading system. And of course it's not. In the episode, we clearly said that symptoms don't declare themselves. They're not obvious. This is how these things get missed. So to say something is symptomatic, mildly symptomatic, or, affecting their activities or whatever that grading said, assumes that both the patient or the doctor, practitioner, can pick up that there's a symptom, but fatigue or esophageal pain or whatever, right, may not fit into this. And this is myocarditis predominantly, or it's cardiovascular CTCA?
That's just myocarditis specifically. There's other classifications for
So
other
here,
stuff.
can I tell you that ASCO has clinical practice guidelines, and they have graded myocarditis. This might be helpful. Grade 1 is abnormal biomarkers or abnormal ECG, EKG, as you say on the episode. We bastardize it in the US. Grade 2, mild symptoms. So now we add in the symptoms on top of the abnormal biomarkers for ECG. And remember, and you and I know this, a portion of the population is already walking around by this definition as grade 1, an abnormal ECG or abnormal biomarkers. Grade 3, ejection fraction less than 50% or regional wall motion. This puts a lot of emphasis on function, or cardiac MRI, diagnostic of myocarditis, suggestive. Grade 4, life-threatening with any of the grade 1 through 3. It's a little more helpful than CTCAE, but as we just said, maybe we want to grade it grade 1 for ASCO, but that's a 0 grade. That's a nothing for CTCAE. So that gets to some of the problem here. Right.
Yeah.
So do you have more to say about it?
No, I mean, I'm not sure how clinically helpful these things are actually, but as ever, grading systems are needed. So we can not dispute that for trials and various other things. And
that's right.
It wouldn't be the only grading system which
falls
isn't
down
necessarily that useful in clinical practice. So was the next thing something about management of toxicities and referring to guidelines? So just I'm biased, obviously, in all sorts of different ways, but the ESMO clinical practice guideline it's called Management of Toxicities from Immunotherapy, and the last update was 2020, and John Hannon's the lead author. I'm involved as well, and actually just quickly maybe talk about my friend Alex Lyon, who's a cardiologist, was
mentioned him on the episode.
Yeah, Alex was also involved. I'm just double checking we don't have any other cardiologists I'm going to offend who are involved. Anyway, so the ESMO guideline, I'm just looking at the figure now, which is it's freely available. Is divided up into symptoms and clinical status as sort of one column. So, for example, chest pain, palpitations, dyspnea, syncope, pre-syncope, lower limb edema, and then the other kind of important bullet there is to exclude acute coronary syndrome, i.e., vascular problem. Actually, I think you always need to think about that, but particularly, obviously, in people who've got a history of coronary artery disease or risk factors. And then the next block of it is assessment investigations. You probably don't need to labour that too much because I think we've talked about quite a lot of it. And then the final bit is about treatment. And mainly, as we've discussed, it's going to be giving high doses of intravenous steroids if you're worried, getting things under control. Often, actually, I would say as judged by the troponin, but also the clinical status, I guess, of the patient. And then once you've got things under control, then go for oral steroids, 1 milligram per kilogram of prednisolone with weaning as appropriate. So I think all that stuff's relatively uncontentious, and obviously you're going to need rhythm support. You might need LV function support as well, depending on how sick people are. But of course, the real bit is about what you do if steroids aren't working, or steroids are working to start off with and they stop working, and that's when the sort of laundry list, with all due respect, comes in, so-called second-line immunosuppressive agents. So this list, examples given are tocilizumab, mycophenolate, potentially ATG, antithymocyclomin, alemtuzumab, abatacept, CTLA-4 agonist, and then that's the list. So my sort of favourite one, as you know, is ruxolitinib, and it doesn't feature there, and I don't think that's a criticism, but these guidelines were 3 years ago. I think the retrospective data at the moment actually are pretty positive, I think, anyway, for ruxolitinib, but obviously we're crying out for prospective data and biomarkers to try and figure out how to treat patients in that situation.
Yeah, I agree with everything you said.
Oh, excellent. That doesn't happen often, does it?
Hey.
Now, what else did we need to do?
Along those same lines, it was what does NCCN guidelines say about management or I'll divert us here in a second. NCCN says basically what you said. Discontinue the immunotherapy, tailor it to the acuity of the presentation, i.e. high-dose steroids for concerning, if no improvement. And they say if no improvement within 24 to 48 hours. So they don't give it a lot of time for improvement. They want this to work pretty quickly. Then it's all the things you said. Infliximab is mentioned. Interestingly, tocilizumab is not mentioned here in the NCCN. Methotrexate is mentioned, and plasmapheresis is mentioned. Abatacept with ruxolitinib is mentioned with a footnote. And then they even said maybe temporary or permanent pacing might be required. So then we talked about related do all the guidelines just basically say steroids? No matter what your side effect, pruritus, hepatotoxicity, colitis, does it just say steroids? And you said, yeah, probably for all of them except endocrinopathies. And I said, oh, I think, some of the guidelines do say steroids for endocrinopathies. So here's what NCCN says. For hyperglycemia DKA, you're absolutely right. It does not say steroids. It does manage it like DKA or new onset diabetes. Hypothyroidism, it says if it's clinical hypo, you can continue the immunotherapy and replete. It only replete the free T4 basically if the TSH elevation persists. So you don't have to treat asymptomatic, but if it persists, then you could. If they become symptomatic, treat it. Overt hypothyroidism, consider endocrine consultation, consider cortisol to make sure it's not concomitant adrenal insufficiency, and then replete the thyroid hormone, not steroids. And then if it's thyrotoxicosis, it is propranolol. And it's interesting, I've seen a lot of our management in the US include steroids here. So it's propranolol and prednisone that I usually see during the thyrotoxicosis part. Yeah, I usually just do methimazole and propranolol. So I usually bind up all the excess thyroid hormone, but I tend not to do free T4. And I don't even see methimazole in these guys.
Yeah, I just beta block those patients. I really don't like. I've seen a few other drugs being used, propylthiouracil, for example, which is hepatotoxic, and pretty much every time I've seen that used, and I haven't been involved when I've seen it used, shall we say, because I would have a strong view not to use it. Patients have then gone on to get transaminitis. So really quite striking. So I think with hyperthyroidism, you just need to make sure the patient's okay, rate control them, and then usually that's enough, and typically it'll burn out quite quickly anyway in a week or so.
That's right. Yeah. Basically, I cannot find an endocrinopathy that starts with steroids. So, as usual, the more senior oncologist here.
Maybe
the more senior, the more attractive,
yes,
the more charming, the better accent.
The worse stressed.
Oh.
No, but I was going to say, I mean, it probably is worth stressing, though, that I think you still see Addisonianism missed quite a lot. And I think you always need to think about that in someone who's sick. So I would just always have that kind of blanket caveat. If you're worried that someone could be Addisonian, then that would be the situation you to give IV replacement steroids. Because I honestly still see that being missed now. And I'm not saying it's particularly common, but it happens.
Would you say the steroids that need to be replaced are physiologic dose, or you think it needs to be higher than physiologic dose?
I mean, I'd normally in someone sick, I'd go higher than what is regarded as physiological dose of hydrocortisone, 10-5-5 or something like that. I mean, if you've got someone sick in front of you, I'll go for IV hydrocortisone at a decent dose, like 50 milligrams, to just remove it from the equation in a sense.
Yeah, stress.
Sometimes, yeah, exactly. Sometimes that can get complicated with people who are worried are septic, but at the end of the day, you don't want something so easily reversible to be not treated.
I think you bring up a nice point, which is for these situations that don't actually present very clearly, Addison's, cardiac toxicity, to some degree neurotoxicity, just don't forget to check on it. Don't let your patient leave with some vague side effect or symptom without your arms around some type of diagnosis here.
Yeah. Or if not, a very close follow-up. In other words, sometimes you don't know. Sometimes there's something wrong and you can't, like I've said before, it's not there's an inflammatory toxicity picture, but it hasn't settled on an organ system. So that type of patient, if you're going to let them go home, then you need to make sure they're sensible and that they're going to report back quickly. We're going to see them again soon, because these things will settle, usually within a few days in my experience.
Yeah, days. I agree with that. Like a couple days later, see them back.
Yeah.
Probably don't even let it go the weekend.
Yeah.
Okay, and then the last thing that we were going to fact check, or that I had asked you, and I think both of us agreed we didn't really know, is there a checkpoint inhibitor that is more likely to cause these cardiac toxicities, i.e. myocarditis, or others, cardiovascular disease, acceleration? Is there one checkpoint or one combination that's more likely? And you said, which is, again, shows your experience, said it's always going to say ipi-nivo. The literature right now is going to blame ipi-nivo for everything. We've got a huge amount of literature on that in melanoma and across other diseases. And the other checkpoints or monotherapy or just the other combinations have not been used as long.
Yeah, absolutely. Agree with that. I mean, and I don't know if it mentioned other anti-CTLA-4s. Just as I don't really want to do a fact check of a fact check here, but bear in mind that there are other anti-CTLA-4s around tremelimumab. I think is the kind of the next one that's most developed. So I would sort of, if you're thinking about durvalumab and tremi, for example, I would sort of bracket that, at least in principle, with ipi-nivo in terms of possibility of myocarditis. Just
Good
as
point.
a kind of earlier clinical development, to be fair. So is that everything? We just need to do the advert. Wow, this is already a 15-minute fact check.
Crazy. And the episode is 48 minutes. Yikes.
Is that too big? It might be, actually, mightn't it? So we were going to finish, weren't we, with mentioning this session at ESMO coming up.
2025, just for the record, for the archive.
Just say the date, yeah, exactly. Saturday, the 18th of October, 2025. And I think this is a joint session, actually, between ESMO and the European Society of Cardiology. So that's good, I think, because it's interdisciplinary, multidisciplinary working. I'm obviously biased because I'm involved in the session, along with a few other oncologists and cardiologists. And if this information comes out in time, it's in the Koblenz Auditorium, Hall 5.2, 10:15 local time in Berlin till 11:45. Navigating immunotherapy-related cardiovascular risks and cancer. So I'm hoping that's going to be a nice session. And there's lots to talk about as well.
Isn't there a subtitle, like when does the oncologist need to call a cardiologist?
You're asking for the subtitle, and the subtitle is When Does Oncology Need a Cardiologist?
So I think you said you're biased because you're in the session. You were appropriately humble about being asked to be in the session. For the record, you had great humility about it.
Yeah, I mean, I think there's some card-carrying experts in this session, so I'm a bit of an imposter, but, I'll try my best.
Okay, well, thanks for this. This was fun.
It was fun.
Okay.
Bye.
Bye.